Welcome to our live stream, Developmental Hip Dysplasia, the Silent Disease. Thank you for joining us. My name is Eric, and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this live stream technology. At any time, you may adjust your audio using your computer volume settings. For closed captions, click the CC icon in the bottom right-hand corner of the video player. Select English to enable closed captions. The Q&A polling tab is where you will ask the presenters questions. You will need to enter your first and last name to participate in polls or to ask a question. To ask a question, click in the text box and type your question. When finished, press the Enter key or click the paper airplane icon to send the question. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. We are joined today by our speaker, Dr. Joshua Strassberg. Dr. Strassberg is a board-certified pediatric orthopedic surgeon specializing in pediatric sports and trauma injuries, as well as hip disorders. He is trained in the latest arthroscopic and minimally invasive surgical procedures, including the latest surgical techniques for reconstructing the ACL in the growing child. At this time, I would like to turn the microphone over to our speaker, Dr. Strassberg, for opening remarks.
As he said, thank you. As he said, I'm Dr. Josh Strassberg from the Pediatric Orthopedic Center here in Cedar Knolls. I want to thank all of you for coming out and joining us. I want to thank Atlantic Health for putting this all together. Today, I'm going to be talking about developmental dysplasia of the hip. So what is DDH? So DDH actually was previously thought of as CDH, or congenital dislocation or congenital dysplasia of the hip. However, since some of the cases arise after birth, our legal colleagues helped to change the name to developmental dysplasia of the hip. Now, DDH is actually a grab bag term. It is not just one thing. It actually encompasses acetabular dysplasia, or an abnormal shape of the acetabulum. It involves subluxation or some laxity of the hip where the ball can move around in the socket, or to the extreme, frank dislocation of the hip where the ball is no longer sitting in the socket at all. There's also what's called a teratologic dislocation, which are irreducible dislocations at birth. This is a separate category. Generally, these are going to be associated with disease processes like arthrogryposis, spina bifida, or some other disorders. Today, I'm going to be focusing really on developmental dysplasia of the hip. So how common is DDH? Well, there is some level of instability seen in about 1 in 100 patients. That can be due either to hip dysplasia or to physiologic laxity. A large portion of those will resolve on their own over the first couple of months. The incidence of true dislocations is closer to about 1 in 1,000 births. So what causes hip dysplasia? There are a number of factors. It's multifactorial. You have genetic and ethnic factors, you have intrauterine mechanical factors, and you have postnatal influences. So what that means in English terms, with genetics, as I said, about 1% of people will have some level of instability or hip dysplasia. If you have a sibling with hip dysplasia, that rate goes up to about 6%. If you have a parent with hip dysplasia, that goes up to 12%. A sibling and a parent, your risk is 36%. And if there's an identical twin with DDH, that jumps up to 40%. Now, it is also seen more often in females than males, anywhere from 2 to 4 times more common in the females than the males. There are definitely ethnic factors. So there's certain ethnicities who have a higher risk of hip dysplasia. So we see this more commonly in Native Americans or in Central Europeans, such as the Swiss. We also see a lower incidence in Sub-Saharan Africans and in Chinese. Now, the intrauterine factors are caused by mostly the size of the uterus upon birth or the position of the child. So patients that are breech have a significantly higher risk than patients that are not, and that goes up to about 12 to 24% risk when they're breech. And this is highest actually in patients where it's frank breech, where the hips are flexed up and the knees are extended so the feet are up by the hip. The reason that the uterus plays a role very often is because If the uterus is cramped, it puts a lot more stress on the hips. So we see this very often where the patients are firstborn, where the uterus hasn't been stretched out. We see it in high birth weight babies where, again, they're cramped into the uterus. If there's oligohydramnios, where there's limited fluid in the uterus, or if there's multiple gestations where you have 2 or more children trying to fill that little space. The most common hip is actually the left hip. And the reason for this is that the most common lie is the left occiput anterior lie, which puts excess stress on the left hip when it's adducted or brought towards the midline. Now, because of the cramped position, there are other things that we will see that also are caused by cramping. Things like torticollis or contracted muscle in the neck, metatarsus adductus, where the feet are misshapen or curved, or the calcaneovalgus foot, where the hip is, or sorry, where the knee, the ankle is hyperdorsiflexed. Some of the postnatal factors are due to the way that the children are treated. So one of the things that we see is patients who were swaddled, particularly on a cradle board or in a papoose. It forces the hips into flexion and adduction, which really kind of pushes the hips a little bit more up and posteriorly, which can affect the development of the hips. On the other hand, things like the backpacks or the tummy packs, like the baby Bjorns, which hold the hips flexed and abducted, that actually locks the ball in the socket so that it actually can help with development of the hips. Now, there are a number of risk factors, like I discussed, being breech, being female, being firstborn, and family history. Those were all mentioned earlier. When you combine all of those, that's a major red flag. So if you have a baby that is a firstborn female that's breech, as far as I'm concerned, that's hip dysplasia until proven otherwise. Now, the goal with hip dysplasia is to try and diagnose it early when the treatment is most effective. So the next question is, how do we diagnose hip dysplasia? Well, there are a couple of tests that are very common that are taught to the pediatricians and to the PAs and to other orthopedists, but they're not always entirely understood. You have the Ortolani and Barlow test, named after Doctors Ortolani and Barlow. The Barlow test basically looks to see if the hip is loose enough that you can dislocate it, whereas the Ortolani test is basically seeing if the hip is dislocated and you're able to reduce it. As you see over here, we have the evil Dr. Barlow and the very happy, kind Dr. Ortolani. For the Ortolani maneuver, the way this is performed is by flexing the hip and the knee, and then putting the thumb on the inner side of the thigh with the index and middle fingers on the outer side of the thigh. And what you end up doing is abducting the hip or bringing it out to the side while pushing the hip forward. If the hip is dislocated and then reduces with this maneuver, you'll hear or feel a clunk as the head pops back into the socket. Now, the Barlow maneuver is the opposite. So you use the same hand positioning, but instead you actually adduct the hip or bring it towards the midline and then push backwards on the knee. And this actually will see if the hip is loose enough where the hip will actually dislocate. And once again, you'll hear that clunk as the head goes out of the socket. So people always talk about clicks and clunks, and it sounds like those are very much the same thing, but they're really not. And the first time that you actually feel the clunk, and the first time I remember feeling the clunk, it becomes very obvious what the difference is. So the clicks are usually like a little snapping. So like if you click your tongue, and it's usually from one of the soft tissues like the tendon snapping over the trochanter of the hip or the knee. And these really are of lesser significance. The clunk is really more of a deeper funk, where you actually can feel and hear the ball popping in or out of the socket. The clunk is really what we're looking for to get a sense as to who we need to be concerned about. The problem with the Ortolani and Barlow tests is that as the babies get older, above 3 months of age, they become a little bit stronger. They can be a little bit more resistant to the exam, and it can be a little less reliable. So there are a number of other exams which can help to differentiate which babies may or may not have hip dysplasia. And mostly what we're looking for are asymmetries. And the most reliable one is if there's a limited abduction of one hip versus the others we see in this upper left corner. The Galeazzi sign, where both of the hips and knees are flexed. With this, the dislocated extremity will look will look shorter. If you have a dislocated hip and the leg is relatively shorter, you also may see an asymmetry of the thigh folds, where there's a couple of extra thigh folds seen on the affected side. You can also see telescoping of the hip, where you push it up and down, which is really kind of similar to the Ortolani and Barlow examination. Another one that's not used as often is the Klisic test. With this, you're actually putting your index finger on the anterior superior iliac spine and your middle finger on the greater trochanter. If the hip is sitting in place and you draw the line between the two, that will direct you above the umbilicus. If the hip is dislocated and sitting higher, it makes that line a little bit more horizontal, and the line will actually cross below the umbilicus. Now, once you start getting to much older stage, where the child is walking, if the hip is dislocated, very often you'll start to see some gait irregularities, either where they have this Trendelenburg gait, where you lurch over to the affected side when you're weight bearing on that side, or you may see a relative limb-length discrepancy where the affected side looks shorter and causes the patient to have to walk on their toes. Now, because you don't see asymmetries when you have both hips dislocated, it can make it a little bit more difficult. There's no obvious asymmetry that's there as far as the thigh folds or the abduction, but if there's limited abduction, even if it's symmetric, that's one where we have to be concerned about possible hip dysplasia. So if there is less than 60 degrees of abduction, we generally are going to recommend either an ultrasound or an X-ray, depending on the age of the patient at that time. The other thing that you can see with bilateral hip dislocations is that very often the perineum is wider. They may have more of a waddling gait than your typical toddler. And there also may be some hyperlordosis of the lumbar spine, as we see here on the right picture. So we have suspicion, either from the history or the physical exam, what's the best imaging? So we really have two options. Either you can look at an ultrasound or you look at an X-ray, and they each have their advantages and disadvantages. Now, generally under 6 months of age, we'll typically go to the ultrasound. And the ultrasound can evaluate both the shape of the acetabulum as well as the stability. Now, to get your bearings, it's not very easy to read an ultrasound. If you look at the picture on the left, that's the X-ray of the hip. To get a sense as to what you're looking at with the ultrasound, if you rotate the hip, the X-ray 90 degrees counterclockwise, so the patient is laying on their side, that essentially is the view that you're getting with the ultrasound. So to get a basic idea of the anatomy, if you look on the left and you look on the right, you have at the top, you have the gluteus medius muscle, and that's overlying the gluteus minimus muscle. Below that, you see the tendon of the rectus femoris, and then below that, you'll actually see the hip joint, and you can see the cartilage of the acetabulum, the femoral head, and the greater trochanter. And then really one of the most important structures that we see here is that kind of horizontal line on the left side, which is the ilium, or part of the pelvic bone. Now, to determine what is a good ultrasound or a bad ultrasound as far as how the hip looks, we have a couple of measurements. And there's really two ones that we look at on the static portion of the exam. The first is the alpha angle. And what that's doing is it's drawing a line in line with that iliac bone, and then it's drawing another line along the roof of the acetabulum. And you're measuring the angle between those two as described over here. Now, the higher the angle, the more vertical that line is, which means that the hip itself is better shaped. The smaller the alpha angle, the more horizontal that line is, and the shallower the hip is. And you can see on the left that there's a very different appearance than what we see on the right, where you really don't have much description of the acetabulum here. The other thing that we look at is how much the acetabulum is covering the femoral head. So if you look on the right side, you can see in the ball that there's a tiny little white dot, which is the ossification center, or the center of the head. You want the acetabulum, or the iliac bone, to be covering more than half of that femoral head to know that it's contained. And we see here on the right that that is the case. If we look on the left, we see that that line crosses and covers more than half of the femoral head. Whereas if you look on the right side, you can see that there's a very small percentage of the femoral head that's actually contained. Now, in addition to the static exam, you also have a dynamic exam. And the dynamic exam is basically an Ortolani and Barlow exam with the ultrasound directly visualizing it. Now, this is much more subjective than the static exam. And this is really where you need to have a good ultrasonographer that's doing this. So if we look up on the top, we see that the normal femoral head is basically contained within the socket. If you look below that, you can see how the femoral head starts to ride upwards as if it's trying to come out. And on the right, you basically no longer see the ball at all because it actually has dislocated out of the socket. Now, the advantages to the ultrasound is that this can be very useful prior to the femoral head ossifying. If you look on the left picture, the x-ray down here, there is no ball that's developed. So it makes it a little harder to really get a sense of where the hip is actually sitting. The other advantage, as opposed to an x-ray, which will show you the shape, is that the ultrasound also will show you the stability, as we discussed. Now, the disadvantage of the ultrasound is it's very operator dependent. So you're reliant on having an experienced pediatric hip ultrasound technician. Unfortunately, there are not a lot of those. So very often I will end up getting ultrasounds from radiology centers or hospitals where this is not something that's done commonly, and we'll get very poor ultrasound films or very poor reads on the ultrasounds. And at that point, we basically have to repeat them at a facility that does them more frequently and does them better. Now, the indications are a little bit questionable. There are certain countries where there is a high prevalence of hip dysplasia, such as the Central Europeans, where screening is universal, and they do ultrasounds on pretty much every child because they know that there's a high risk of hip dysplasia. The problem is, the question of cost effectiveness. Now, in a patient population is very diverse, like the United States, you can argue whether it is cost effective enough. You can make the argument, however, that because you end up saving on the back end with the number of hip replacements that are needed, that you may end up actually being more cost effective than it appears. At this point, really what we're using as the indication is based off of the history and exam, and the ultrasound is used to confirm the findings. Generally, because the patients have physiologic laxity in the early stages, that tends by the 6-week mark to have correction of the hip. So if you end up waiting until 6 weeks, very often that physiologic laxity has resolved, where you're not going to get as many false positives as if you decide to ultrasound every single baby at 2 days of age. So typically the protocol for the ultrasound is, if you have suspicion, you do the ultrasound at 6 weeks of age. If everything is normal, you say, "It was very nice meeting you. We don't have to do anything else." The one time where that's different is the breech babies. And for some reason, the babies that are breech, even when they have a normal ultrasound at 6 weeks, there's a percentage of them that, if you repeat an x-ray at 6 months of age, will actually have radiographic findings of hip dysplasia. And depending on the study, it's been shown anywhere from 2 up to 29%. Now, in the years that I've been in practice, I've had a handful of them. So in my experience, it's not a huge percentage, but that's still a handful of patients who will not have hip arthritis when they get older. Now, the x-rays are very helpful. And once you're past the 6-month mark, that's generally what we're using to be able to assess the hips. In early infancy, it can be difficult just because the femoral heads are not ossified and visible. Generally, after 4 to 6 months, you start to see the ossification of the femoral head, and it becomes a little bit easier to get a sense as to where everything sits. Now, there are a number of things that we look at on the x-rays to determine what's normal and what's not normal. So if you look at the left hip, or the one that's on the right, you can see how Shenton's line is intact, meaning the line that curves from the inferior border of the pubic ramus and then continues on to the medial proximal femoral metaphysis. it really kind of stays in line, as opposed to the image on the left where you can see that that line is broken and sitting out of place. If you were to draw a line running from the triradiate cartilage on one side to the other, and then drew perpendicular lines from the lateral aspect of the acetabulum down, normally the medial proximal femoral metaphysis should sit in that inferomedial quadrant, as we see on the right side of your screen. This is as compared to the hip on the left, where it's sitting much more lateral and out of position. One of the big things that we look at for the development of the acetabulum is the acetabular angle. With this, once again, we draw a line through the triradiate cartilage, and then a second line is drawn along the lines of the roof of the acetabulum. With this, generally, you want to see a lower angle, a more horizontal measurement to show that the hip is developing well and is containing the acetabulum, more what we see on the right side of our screen as opposed to the left. One of the other things that we often will see in patients where the hip is dislocated or dysplastic is that the ossification of the femoral head is generally delayed. So with this, very often when you look, the normal hip may end up looking like it's larger than the other side, although it's not truly larger, it just hasn't calcified as much and ends up looking smaller. Now, as we get older, in particular, as we get over to the adolescents and adults, we're really looking at the coverage of the femoral head and what percentage of the head is covered. So we end up using the lateral center edge angle. And with the lateral center edge angle, we're drawing a line from the femoral head on one side to the other, and then drawing a perpendicular to that. The next line is going from the center of the head to the lateral edge of the acetabulum. And this is basically showing us the percentage of the femoral head that's covered. Usually we'll start to use this once they get past 5 years of age, although it's really more effective in the adolescents and older patients. And this plays a big role in determining a lot of our treatment as they get older. Now, because you only see what is calcified or ossified, even though the femoral head is much larger, you only see a tiny little dot. So in patients where it's questionable what we're looking at, we can do an arthrogram, which is basically where you inject dye into the hip joint. What that allows us to do is really get a better outline of the cartilaginous portion of the femoral head as well as the acetabulum. And if you look at the X-ray on the right, the hip sitting on the left, you can see that where the black dye it helps to show you that the acetabulum actually is much more horizontal than it appears just by looking at the bone. And you can see that the femoral head is actually significantly larger than what it appears just from the bone on the X-ray. And in this hip, even though it may look a little bit shallow on the X-ray, when you end up doing the arthrogram, you can see that it's actually much more well-developed than expected. So if there is hip dysplasia and it's not treated, the big question is what happens? So the natural history of acetabular dysplasia, not necessarily dislocation, but acetabular dysplasia, is that there's a high prevalence of going on to develop arthritis. And this actually very often occurs at a young age. So not when the patients are 70 or 80, but in the 30s, 40s, or 50s. And it's estimated that anywhere from 20 to 50% of patients with hip osteoarthritis is actually due to some level of hip dysplasia, which goes back to my commentary about the universal screening and whether or not that really truly is more cost effective to be doing that and saving patients from having hip replacements later on in life. Now, the reason that you end up having this problem is if you look at the hip on the right, all of the pressure is basically being absorbed through a wider contact area. When you look at the picture towards, or the hip towards the right, you have that same pressure, but it's really being placed on a much smaller area. So you have all of that pressure being placed on a smaller area, which ends up causing breakdown. And on the picture all the way on the right, you can see that there is changes where you end up getting damage to the labrum, which is the bumper around the socket, as well as to the cartilage on the top of the socket. Now, patients with dislocations act a little bit differently, and they actually tend to have problems much earlier than the patients just with acetabular dysplasia. So if you have a unilateral dislocation that's not picked up, very often it will lead to a limb length discrepancy where the affected side is shorter. Because of that, you end up having contractures of the contralateral hip to kind of adjust for the limb length discrepancy. And these generally will go on to develop arthritis at a very early age. With the bilateral dislocations, you don't end up getting the limb length discrepancy because both hips are dislocated. However, you will get hip arthritis at a very early age bilaterally. And also you end up getting that increased lumbar lordosis that I showed earlier, which then ends up leading to back pains. So what do we do now? The important thing is you want to try and diagnose them early when treatment is most effective. And the main thing is you want to try and get a safe concentric reduction to allow for normal development of the hip. Because if you have the ball sitting in the socket and putting pressure on it, it's going to develop properly, and vice versa. If you have the socket containing the ball very well, it's going to develop well. And the way I usually try to explain it to patients is if you take a ball of Play-Doh and you're only putting pressure on one side, you're going to start to deform that ball of Play-Doh. If you're constantly putting pressures all around it, you remain with that nice round concentric positioning. So part of the reason we want to get them early is because the body has a much better remodeling capability when it's younger. So generally patients under the age of 4 years old have a significant remodeling capability of the acetabulum. As you get older, you start to lose that ability, and very often you can start to develop an incongruence which exceeds the remodeling capability of the joint. The joint actually will continue to remodel up until 12 years of age, although it's much more limited once you get past 4. Now, there are a number of treatment options for patients with hip dysplasia, in part depending on the age of the patient and whether the hip is just dysplastic or whether it's actually dislocated. So the first thing that we usually will treat patients with is what's called a Pavlik harness. And this is not a new invention. This has been around for many years. Generally, it's used in patients under the age of 6 months. And the concept behind it is that it helps to hold the hips in a flexed and abducted position, which basically locks the ball in the socket. And again, that pressure from the ball pushing into the socket allows the socket to develop around the ball and tighten up to become a little bit more normalized. When we end up putting this on, the hip is generally flexed to about 100 degrees and it's abducted in a safe zone, meaning that it's not over abducted where it starts to put pressure on the blood supply, but it's not under abducted where the hip is more likely to re-dislocate. In patients where the hip was dislocated and we have located it with the harness, very often if I have any question about it, I'll end up obtaining an ultrasound in the harness so that way I can make sure that the hip is actually sitting in position rather than having the harness on, holding them out of place. Now, the duration of time, this is a question that I'm always asked when we start treatment, is how long is my child going to need to be in this? Now, I always tell them, unfortunately, it's not based on what I do. It's really based on their child, and it's based on their response to treatment. So the quicker that they end up responding, the less time they end up having to spend in the harness. Generally, I'll repeat an ultrasound about 4 to 6 weeks after we start the harness. And that's going to help to see how the acetabulum and the femoral head are developing, whether the hip is still loose, whether the socket is still shallow. I find generally infants that are treated soon after birth will respond a little bit faster. Typically, my protocol is I will leave them in the harness for 4 to 6 weeks full time, with the exception of bathing and diaper changes. And then once we have a normal ultrasound, I'll start to wean them from it over the next, honestly, it's anywhere from 2 to 12 weeks, depending on how slowly they go. The only thing that would be a little bit different is if the hip was actually dislocated and I've reduced it, at least that first week until the hip is stabilized, they have to stay in the harness full time, no coming out for bathing, no coming out for diaper changes. I find generally infants that are diagnosed at an older age tend to have to be treated longer. Now, the Pavlik, as much as parents don't like the look of it, the babies tend to tolerate it very well, and it's very successful. Depending on the study, it's listed at anywhere from a 90 to 95% success rate. Generally, the patients that fail are patients that are diagnosed older than 6 months of age, patients particularly who have severe dysplasia that's bilateral, and then you have patients where you have poor technique, either it's not abducted or flexed significantly, or where the parents have poor compliance, where they just choose that they are going to go without the harness longer than they really should. Now, there are complications, but they are very uncommon and they're all avoidable. The two times where you'll see potential complications is one, if there's excessive abduction. The reason for this is that when you have excessive abduction, it can start to clamp down on the blood supply to the femoral head, and you can actually cause a vascular necrosis of the femoral head, which can cause deformity there. The second way that this can happen, or the complication that can happen, is if you have excessive flexion, as we see here on the right side. And with that, very often you can actually pinch the femoral nerve and develop a neuropathy. Now, you can see how extreme this baby's hips are flexed. Generally, the only way that's going to happen is if the parents basically disappear for a couple of months and don't take their baby out of the harness. So that really is highly avoidable. Now, in the patients where they've been treated in the harness but still have some residual dysplasia, I'll usually switch them over into an abduction brace, which is doing essentially the same thing, but it is a little bit more structured with the metal bar and the foam and straps. With this, usually I'll have them wearing the brace for 2 to 3 months, most of the time, not necessarily full time, and then I switch it over to nighttime and napping. With these, I'll usually end up repeating x-rays at 3-month intervals until they've normalized, and then we can discontinue the brace. Now, in the rare patient who has been treated with the harness and the brace and have failed, or in those patients where they weren't picked up until much later, there are times where we do have to talk about doing something surgical. And the most common surgery that we'll do in the patients under the age of 5 is an acetabular osteotomy, a Pemberton or a Degas osteotomy. And with this, we end up making a cut just above the acetabulum and we lever it down. We end up putting 2 bone plugs in there to basically hold it in place, and then the bone fills in that gap. So you're basically bringing the acetabulum down and creating the socket the way that you want it to be. Now, patients that are dislocated under 6 months, as I said, can be treated in a Pavlik harness. Over 6 months is very unsuccessful. So generally after the age of 6 months, we're going to either do a closed or an open reduction. This is done in the operating room. So a closed reduction is where you just manipulate the hip back into place. Typically, I will do an adductor tenotomy, which is basically releasing one of the adductor tendons. So that way they have the ability to abduct or bring the hips out of place, which allows the hips to remain stable. When I end up doing this, I'll usually do an arthrogram, and then in the younger patients where the femoral heads are not well visualized, often I'll have to do further imaging like an O-arm, a CT scan, or an MRI to make sure that the hips are actually in place when they're leaving the OR. They'll typically be, or they are put into a spica cast. Usually it's for 6 weeks, and then we bring them back to the operating room for a reevaluation and a spica cast change. Generally, they're going to be in the heart in the spica cast anywhere from 12 to 18 months, or weeks. My God, 18 months for 12 to 18 weeks in total. When they do come out of the spica cast, I generally do put them into that same abduction brace that we talked about. Once again, looking at them at 3-month intervals to see when I can actually discontinue it. Now, as they get older, unfortunately, the soft tissue tends to contract, which makes it harder for the hip to go back in place. The dysplasia becomes more advanced and the hip and the socket becomes more shallow. And with these, very often you're not able to just manipulate them back into place. And that's really where an open reduction is necessary. And an open reduction means making an incision where you're actually going down to the hip. And the advantage of this is it allows us to remove the impediments to reduction. Now, there is a significant patho-anatomy that goes along with the dislocated hip, particularly hips that have been dislocated for an extended period of time. Like I said, the hips tend to be very shallow. So when you put the hip back in, it's not necessarily going to contain it very well. Very often the capsule or the lining around the joint is very stretched out and loose, so it's really not holding it in place. You end up getting hypertrophy of the soft tissues in the socket, so you get this fibrofatty pulvinar or the hypertrophy ligamentum teres, which ends up blocking your ability to put the ball back into the socket. Typically, when I'm operating on these, we'll end up using the anterior approach, which uses a bikini incision right in the front of the hip. The incision is in the skin lines and it happens to be hidden by the underwear or the bikini, which makes it a little bit nicer for when they're grown up. It also gives me the ability to enter directly into the hip and be able to remove all those obstacles that I talked about, but also be able to plicate the extra hip capsule to really tighten it up and hold it in place. Once again, after we do the open reduction, just like with the closed reduction, they're treated in a spica cast. Once again, will typically end up doing further imaging like an O-arm, a CT scan, or an MRI. And similarly, they are usually in a spica cast anywhere for a total of 12 to 18 weeks. Now, in patients where the soft tissues are really contracted and where you're not able to get the ball back down to the socket, even when you've removed all the impediments, sometimes it is necessary to do an osteotomy or to make cuts in the bone to be able to deliver the ball down to the socket. And usually we'll do what's called a varus shortening osteotomy, which is where you cut the bone below the hip and then basically bend it down so that it can actually direct more towards the socket. As I said, this delivers the head to the socket and lessens the pressure on the femoral head and also decrease the risk of avascular necrosis of the femoral head. Again, with some of these that have been out for a long period of time where they have significant dysplasia, very often we will have to do the acetabular osteotomy as I described before, and it's not uncommon where we may have to do an open reduction alongside the femoral osteotomy and the acetabular osteotomy all at once. So what happens if we fail? What are our options? Well, there have been a number of osteotomies that have been performed over the years, and what really has come into vogue of late is the Gons periacetabular osteotomy or the Bernays periacetabular osteotomy. This was really perfected by Dr. Gons in Bern, Switzerland, and what you end up doing is you actually end up cutting out the acetabulum, though you leave a part of the pelvis intact so you don't destabilize it, and you literally rotate the socket to bring it into position so you get the proper coverage needed for the femoral head. And you can see here on the picture on the left how undercovered it is, and then how well the coverage is on that right side. And you can see the screws that are holding everything in place. Now, unfortunately, in patients where you've missed the boat and they've already developed hip arthritis, your solutions, your options are much more limited. In your younger laborer, where they're bound to put a lot of stress on the hip, where something like a hip replacement may not be a great option for them, you can do a hip arthrodesis or a hip fusion. These can be more helpful in younger laborers. However, in the long term, they're not great because they do put a lot more stress on the lower spine as well as on the contralateral hip. So more often than not, what ends up needing to be done is a hip replacement. Now, hip replacements are a great procedure. They do very well in older patients. So if you're 70 or 80, it's a fantastic surgery. However, when you are 20 or 30 or even 40, in a best case scenario, you're looking at maybe 30 years before you need to have a hip replacement revision. And unfortunately, those don't do as well. So we want to do everything we can to prevent patients from ever getting to that. So I want to thank you all for coming and listening to my talk. I'm not sure if there are any questions that are available or that anybody has. I'm more than happy to stay and answer any questions that come up.
I would like to remind our audience that in order to ask a question, please type your question into the Q&A tab on the right-hand side of the video player. You can type and send your question there and hit enter to send. And at this moment, we do not have any questions. While we do wait for questions to come in, do you have any frequently asked questions that you would like to address?
So some of the questions I had mentioned, initially when we start the harness, parents want to know how long they're going to need to be treated in it. And as I said, it really depends mostly on how quickly the babies respond. I find generally the patients that are caught much earlier tend to respond much quicker. Patients who are caught later have a tendency to take longer, although it's not always the fact. And I've had some young ones who have taken a while to respond, and I've had some older ones that kind of responded very quickly. So it really depends on what we're seeing on the ultrasound and on the x-ray to determine how long it's going to be. So I see we have one question. In primary care, we appreciate a clunk better to order imaging or just refer out. In general, if it is an obvious clunk, I would tell you you're better off actually just sending them in, because at that point they're going to need to be treated. And if it's a very obvious dislocation, typically I won't end up getting an ultrasound right away. If it's a patient where it's questionable, or as I said, if I feel like I put the hip back in place, but it's questionable as to whether it's staying there, that's where I'll end up getting the ultrasound. So if it's an obvious clunk, I would tell you you're better off sending the patient in. If it's a click, some pediatricians feel more comfortable having it seen by an orthopedist before determining whether or not something is necessary. Some of the pediatricians are comfortable just ordering the ultrasound. The big thing I would tell you is I would wait at least until 6 weeks of age to make sure that any physiologic laxity has had a chance to resolve. So I have a question. Did you state that toe walking is one of the indicators of this? If so, is that the cause for adults who are toe walkers? So it's actually not exactly what I was saying. One of the things that you'll see is not necessarily toe walking, but toe walking only on one side. So if you're toe walking on both sides, that's not an indication for hip dysplasia. If you're toe walking only on one side, that's generally an indication that one leg relatively is shorter than the other, which could be either that the leg truly is shorter than the other, or that the hip is dislocated so that it's sitting higher up and relatively looks shorter compared to the other side. And then in order to basically even it out, they start walking on their toes on the affected side. So what type of breech babies are more prone for congenital dislocation of the hip? So the most common affected breech presentation is going to be the frank breech presentation, because that puts significantly more stress on the hips even than your basic breech. It's interesting that there's no studies that I'm aware of that really are able to talk about how long they need to be breech or what portion of the pregnancy they need to be breech. There's some babies that are found to be breech at a younger portion of the pregnancy, but then end up flipping. There's some that are there for a longer period of time, but then flip at the end, so they don't have to be a C-section. And then there are some where they look normal all throughout the pregnancy, and at the very end seem to flip. I don't think there's enough data out there to be able to determine which ones are higher risk than others. So considering that ultrasounds are not an insane cost, granted it is a cost, but they're not as expensive as many other tests, as there's no radiation associated with it. I think with any baby that is breech, you're better off getting an ultrasound to be able to be sure that they're not going to end up missing the boat and having hip arthritis when they get older.
Okay, that does look like all of the questions that we have. Do you have any final comments that you would like to leave us with?
No, basically, this is what we do for a living. Yeah, and I know that I get questions from pediatricians, from patients all the time. If you ever have any questions, you can always end up reaching out to to me, I have plenty of times where I can give you a very simple answer, and it's not always necessarily the answer that you think. And a lot of times it can end up saving your patients a lot of running around and heartache.
Well, thank you so much for that great presentation. And on behalf of Atlantic Health System, Morristown Medical Hospital Pediatric Orthopedics, I would like to thank you for your participation in today's event. You will now be redirected to the post-event survey requesting your feedback. Please take a moment to complete this survey to receive credit for providing feedback and attending today's webinar. This concludes today's stream. Thank you and have a great day.